Good morning, respected teachers. I'm presenting today a case of 31-year-old male from Ganganagar, who is a factory worker by occupation, who presented with the chief complaint of yellowish discoloration of eyes following an open cholecystectomy around 3 months back. So patient was coming to history of present illness. Or patient is a 31-year-old male who was a known case of gallstone disease for last 10 years with history of on and off right upper quadrant pain. However, there was no history of fever, nausea, vomiting, jaundice, abdominal distension, other sensorial. He was admitted and evaluated with a USG abdominal elsewhere and underwent elective open cholecystectomy on 11th of December 2021. The surgery lasted for 3 hours, and after surgery, the specimen of the gallbladder with the multiple stones was shown to the relatives. The relatives were also counseled for the difficult surgery and the blood loss. However, there was no intraoperative blood transfusion given and no drain was placed, and patient was shifted to ward after the surgery. He was allowed only on post of day 1, which he tolerated well. On post of day 2, he complained of pain in right upper quadrant abdomen, which was moderate to severe intensity, dull aching and radiating to back. It was also associated with jaundice, which was progressive and associated with the passes of clay stool and pruritus. However, there was no history of fever, abdominal distension, low urine output, or altered sensorium. He was further evaluated via abdominal imaging at the same center, and then after he was continued to be managed conservatively, following which his symptoms only partially improved, but didn't completely resolve. There was no history of any other intervention other than these abdominal imagings post-operatively, either a endoscopy or USG guided intervention. And he was discharged after 10 days of hospitalization with the advice to regular follow-up. He now presented to us with the complaints of progressive developing jaundice, which was associated with high color urine and clay color stools and pruritus for last 3 months. He also gave history of loss of appetite, but there was no history of fever, nausea, vomiting, jaundice, abdominal distension, altered sensorium, decreased urine output, hematemesis, melena, or significant loss of weight. There was no history of dry eye, bony pain, muscle weakness, easy visibility, or fatigue also. There was no other history of any surgical intervention other than this, and there was no history of tuberculosis, asthma, or COPD. There was no history of diabetes, hypertension, or hypothyroidism. There was no personal history. He is a vegetarian, non-alcoholic, non-smoker. He has disturbed sleep pattern due to generalized itching. However, there is no history of any chronic drug abuse or any known allergy. The family history was also not contributory. To summarize, my patient is a 31-year-old male without any addictions or comorbidities who presented with painless progressive cholestatic jaundice and loss of appetite for last 3 months without any features of cholangitis, following undergoing elective open cholecystectomy for cholelithiasis. Sir, should I discuss?
Yeah. So what do you think could be happening here?
So, sir, patient underwent a difficult open cholecystectomy surgery 3 months back. So maybe he has a sir.
Yes, please carry on.
So and he had jaundice on post of day 2. So maybe there was a incident of bile duct injury after surgery, during the surgery, which led to these symptoms.
So if you say it was a difficult gallbladder and there was bile duct injury, in the history, is there any evidence to suggest that there was bile leak?
No, sir. No, sir. There was no history of bile leak, but patient on post of day 2 had jaundice, and it was progressive also in nature. So maybe the surgeon had actually clipped the common bile duct rather than causing the injury which is leading to bile leak, sir.
Yeah, so again, the two things are not synonymous. Most bile duct injuries will have bile leak, but you can have a bile duct injury without bile leak, isn't it?
Yes, sir.
If you have a clipped duct, ligated duct, there will be no bile leak till the clip sloughs off. At the same time, you can have bile leak, but you may not have a significant or a major bile duct injury. For example, if it is a cholecystohepatic, although in classification, all of them will come as bile duct injury, but they are not probably clinically significant because they don't involve the main bile duct. So cholecystohepatic duct, cystic duct leak, cystic duct blowout, they will have bile leak, but there is no major or main bile duct injury. Now, in this case, clinically, at least on the history, there is no indication to suggest bile leak. Why do you say so?
Sir, I'm saying bile duct injury, sir, not
No, bile leak. You said there is no evidence of bile leak.
Yes, sir. Yes, sir.
So what are the points in the history which suggest that probably there was no bile leak?
Sir, the surgeon in intraoperative notes, he didn't, intraoperative course, he didn't mention that there was to relatives that there was any injury associated to bile leak, and also he didn't place the drain also, considering that he may be thinking of future bile leak, sir.
And in the post-operative period,
and the
what
post
symptoms?
also patient didn't had any sign related to bile leak like fever or any abdominal distension or signs of peritonitis. So symptoms of peritonitis. So that's why, sir. And patient only had a symptom of jaundice only, which was progressive. So most likely there was a clipping of the bile duct rather than a leak from the bile.
And also, you said that the patient underwent some abdominal imaging.
Yes, sir. Yes,
so
sir.
if imaging was done and no intervention was done, like placement of a PCD, very likely that they did not see a bile collection, isn't it? So
Yes,
these are just corollaries. These are just things which we are guessing. So in this patient, clinically on history, there is no suggestion of bile leak. His main problem was pain and jaundice on day 2.
Yes, sir.
What else would you think if the patient after cholecystectomy on day 2 has pain, which is the significant pain, and jaundice?
So there is another possibility of a retained CBD stone, sir. Which can be symptoms, sir, in post-operative period, sir.
So bile duct injury usually will not have severe pain. The
Yes.
pain in bile duct injury will be the pain of bile leak, biloma, which is usually mild to moderate, dull, diffuse ache rather than severe pain of biliary colic. So if the pain is a significant symptom and jaundice has occurred, in fact, I would probably at that stage think more of a CBD stone rather than a bile duct injury and bile leak, isn't it?
Yes, sir. Okay, sir.
What else in the next 3 months? How do you explain what is happening?
So, sir, next 3 months, so initially he was managed conservatively only abdominal imaging was done. So, and there was no intervention was done. So that was a point against the CBD, retained CBD stone. And maybe patient had only a clipped bile duct. So he was followed up for the next 3 months, and then after planned for further intervention. So
Yeah, so the fact that they did not do any intervention for 3 months, although his jaundice is gradually increasing, is a point against stone, because if they would have detected a stone, they would have done some intervention. So the course of jaundice, 3 months, and here you say painless progressive jaundice. In the summary, you are saying painless progressive jaundice. So if the pain did not occur later and it is a progressive jaundice, it is not intermittent jaundice, these are points against a retained CBD. So,
any relevance that you said the patient had undergone an open cholecystectomy in this era?
Sir, there are few probabilities. Maybe as patient has a history of long duration gallstone disease and he's a male patient, so maybe on pre-operative investigations, the surgeon anticipated that it will be a difficult gallbladder surgery. So they directly went for an open surgery, or maybe the facility of lab cholecystectomy was not present at the center, or maybe the patient patient on the pre-operative imaging may had a simultaneous CBD stone also. So that's why they went for the open surgery to do the CBD exploration also. Or maybe there was a risk of, very less likely, but risk of on imaging risk of carcinoma GB also for open surgery. So
So usually in that case, the patient in his history will tell whether he was told that possibility of laparoscopic surgery is less and we will directly do a open cholecystectomy, or there will be a history that the patient will be told that we will try to do it laparoscopically, but possibility of conversion is very high because it is difficult. Third thing is patient will be told that on your pre-operative sonography findings, we have a finding which will suggest, tell us that possibly because of this reason we are going. So that is normally the counseling part which the family is done. Was the family counseled or was the patient counseled pre-operatively? That is in the history part.
No, sir, he was not counseled. He was
He was not knowing. So he had agreed directly for an open cholecystectomy.
open cholecystectomy.
So, yes, Dr. Chaube wants to say something.
Ashish,
One.
post cholecystectomy, he developed jaundice on second post-operative day, and he was kept in the hospital. And you did not tell that if the ultrasound was done, what was the finding? Because based on that finding only, they might have kept him, and then he improved to whatever conservative management, and that would have ensured that there is no collection inside. It's not a injury to the bile duct. I mean, semantically speaking. And what was the advice? Because it looks from this history and presentation that it probably the bile duct was tight, because he developed the jaundice only second day. And he must have been given some advice that 10 days you have kept in the hospital, that you go to some higher center, or you come back after this time, we will say, do surgical management. Something a patient must have been given advice at the time of discharge.
Yes, sir. As I mentioned, sir, he was advised to regular follow for further period of time, sir. He was advised for this after 10 days of hospitalization, sir.
Okay, suppose I tell you that the center where this cholecystectomy was done had the facility for lap chole, but by choice, the surgeon went for an open cholecystectomy. What could be the possible reason? And which also caused the cholecystectomy to be difficult, because you yourself said that it took 3 hours and you think it was a difficult gallbladder.
So, sir, basically, the two things are there in the history. First, the patient has a long history of gallstone disease, like 10 years history of gallstone disease. So these types of colonic cases tends to have a contracted fibrotic gallbladder, which are difficult to manage by endoscopy. And most of the time, the colors are also frozen in these cases.
No, but if you can do a lap chole, would you do a direct open cholecystectomy for a contracted gallbladder?
No, sir. No, sir. No, sir. We will not.
So again, listen to the question carefully. I told you, center has facilities and expertise for lap chole, but still in a particular case, they go for open cholecystectomy. What will be that situation?
So that can be a high suspicion of gallbladder carcinoma.
Yeah, so you have to bring that point in, that on pre-operative imaging, they probably had the scenario which I am giving you, center which does lap chole will not go for lap chole, may go directly for open chole if there is a suspicion of malignancy.
Yes.
So how will that suspicion come? What will tell you that there is a suspicion of malignancy?
So there are clinical and radiological parameters, sir, which may be suggestive of this. So clinically, patient is having history of long gallstone disease, and also patient may have history of loss of appetite and loss of weight also during the presentation. On USG examination, patient may have a thickened gall bladder with lymphadenopathy or without lymphadenopathy, or having any surrounding infiltration, which may suggestive of a possible gallbladder carcinoma, sir.
So the commonest reason for suspicion of gallbladder malignancy would be a thick-walled gallbladder.
Thick gallbladder, sir. Thick
You
gallbladder.
have to say that term, thick-walled gallbladder, more so if it is focal, irregular, non-uniform thickening, rather than diffuse, regular, uniform thickening. Because if you see diffuse, regular, uniform thickening of the entire GB wall, it is more likely to be inflammatory.
Yes.
If you see focal, irregular, non-uniform thickening of the gallbladder wall, it is suspicious of malignancy. So would you like to know what preoperative imaging was done in this case?
Yes, sir. Yes, sir. I would like to know what we were doing.
So do we know?
No, sir. These parameters were not available. He was referred to us. So
yeah, very soon, if the patient says that after an ultrasound a CT was advised, you know that it is not plain simple gallstone disease. That means the surgeon had a suspicion. That is why CT would be done. Otherwise, normally you would not do. So all this becomes important, more so because you are saying it is painless progressive jaundice.
Yes.
So how can you put these two things together? Suppose I tell you that in this case, ultrasound showed a thick walled GB. They also got a CT done. It was a difficult cholecystectomy, and the patient has painless progressive jaundice with some loss of appetite.
So, sir, so patient may have now the incidental gallbladder carcinoma that can be detected in histopathology postoperatively, sir.
Did you mention about the histopathology of the gallbladder
Sir,
in your history?
Sir, I want to know in the reports that I.
But did you say that you want to know the histology of the gallbladder? You should have said that, isn't it? So any patient who develops jaundice after cholecystectomy, especially if it is uneventful cholecystectomy, that means there is no bile leak, then you, not as the first possibility, but as a second or third possibility, you have to keep what is called a missed gallbladder cancer. That means the gallbladder cancer at that time was missed, and now it is recurrence or residual disease, which is manifesting as painless progressive jaundice. What are the point against it being a missed gallbladder cancer?
Sir, first thing is basically the age of the patient, and patient preoperatively didn't had any.
You see, I never mention age as a point, or against a diagnosis.
Yes, sir.
It's not a good idea, because we all have seen malignancies at young age. So don't mention age as the first point.
Yes, sir. So, sir, clinically patient.
Yes.
Clinically, patient didn't had loss of appetite preoperatively or significant loss of weight, and patient had developed jaundice on post of day 2 of the surgery.
Yeah, very important. You see, if the patient develops jaundice on day 2, and I don't know whether you mentioned or not, but you should have mentioned, or you should have said, I would want to know whether pre-operatively there was jaundice or not. So if pre-op there is no jaundice, LFT is normal, and suddenly on day 2 patient develops jaundice, it is very, very unlikely that this jaundice is because of a missed gallbladder cancer. It is something which has happened during the surgery, isn't it?
Yes, sir.
Yeah. So suppose I say that this jaundice is because of a CBD stone. Again, the same point, that pre-op patient has no jaundice, LFT is normal, ultrasound did not show CBD stone. How is it that on day 2 there is a stone which is causing jaundice?
So there may be process of a stone during the
procedure. So if there are multiple small stones with a wide cystic duct, then you can have a stone slipping down during the operation. So very important again to know that how many stones were there, whether they were small stones. So if you have multiple small stones in a situation like this, the possibility that it is a slipped CBD stone during the procedure becomes a high possibility. So this is how you need to discuss each and every symptom. Okay?
Yes, sir.
Yes, yes.
Just a few points, Ashish. You told patient has a history of stone for last 10 years. So there's a possibility that he's having a thick wall or acute cholecystitis or obliterated Calais triangle. I would differ in that opinion, because until this patient has recurrent episodes of pain and fever and recurrent cholecystitis, the duration of stone does not relate with the thickened gallbladder versus a obliterated Calais. It happens only if you have a repeat episodes of acute cholecystitis, that he will have a obliterated Calais triangle possibility. Do you agree with me?
Sir, I actually, your voice was thick, sir, so I can't understand.
When you were asked that he has a possibly a difficult Calais, that you were saying because he has a stone for last 10 years.
Sir.
Actually, it is if he has
repeated episodes of acute cholecystitis along with the.
That is the more important thing for you to mention.
Yes.
Second thing is when sir was asking you about the possibility of gallbladder cancer on table when it was being done, there is usually you can have it on, because since we are still on history, I would say one is USG, as it has been rightly mentioned, but usually the specimen of the gallbladder is shown to the family with a gallbladder. And nowadays, most of the patients take a pic of that, image of that. So that usually gives us a hint that we see that whether the gallbladder was thick-walled or not.
Yes.
Third thing is usually these type of gallbladders which are difficult and such a history, when there is an open cholecystectomy being done, there will be some hint, was it a partial cholecystectomy or was it a complete cholecystectomy? Because most of these injuries happen when you are not able to find the calyx triangle, you do a partial cholecystectomy, suture it, and then incidentally or accidentally you just suture it through one of the sutures goes through the CBD, so that may cause a obstructive jaundice. Second thing is the last point, when you were telling about the stone getting slipped into the CBD, I think which is more common cause of causing a slippage of stone, lap or open?
Lap, sir.
Lap, you know? So this was the open cholecystectomy. Second thing, whether it was a fundal first or it is a calyx first.
So that I want to review in the OT notes.
So we don't know. Usually fundal first is done with a partial cholecystectomy. It is less common that you will have a fundal first with a complete cholecystectomy, because if it is complete, then they will find a calyx triangle easily.
Yes,
Then
sir.
it is less likely to use a fundal first method. Third thing, then you would know from the notes that whether the patient has a dilated cystic duct or not, whether the patient has, whether he has multiple small stones or not. They will give you a hint. These are the subtle markers which can tell you, which can support your diagnosis of passage of stone.
So what we are trying to tell you that in these patients, it is important to elicit the pre-operative and the intraoperative history also. They may suggest to you what is the possible cause. Let's proceed. Let's proceed.
These were my differentials, sir, which we have discussed. So coming to the general examination, my patient is a well-oriented.
Sorry to interrupt, but go back.
So sorry, I missed the.
Yeah, I would say that rather than saying post-cholecystectomy biliary stricture, I would say a ligated or a clip. I mean, since it is open, a ligated duct, because the jaundice appeared on day 2 and it is progressive since then, isn't it?
Yes.
Biliary stricture term we use when we say that there is an injury, then there is a leak, and then fibrosis, and then stricture. This is the ligated duct. Most probably, yes.
So my patient is well-built and well hydrated. He is having weight of 59 kg with BMI of 23.1 kg per meter square. WHO performance status of 0 with pulse rate of 60, BP of 94/68, and temperature of normal body temperature. There is scratch marks present all over body due to pruritus. There is deep icterus present. However, there is no signs of lymphadenopathy or edema. The breath holding time is 20 seconds, and there is no signs of liver stigmata. On oral examination, there is no staining or ulcers. On abdominal examination, on inspection, the abdomen is flat with umbilicus and central inverter. There is yellow discoloration skin is present. There is a scar mark present due to previous open surgery in the right subcostal region, which is around 10 cm long and healed by primary intention. There is no visible dilated veins, peristalsis, fullness, fistula, or sinus opening. There is no impulse on coughing on the hernial orifices. On palpation, the temperature of the abdomen is normal. There is mild tenderness in the right upper quadrant of abdomen. The liver and spleen are not palpable, and there is also no palpable mass present, and there is no bony tenderness noted. On percussion, there is no free fluid. The liver spine is around 14 cm in the right mid-clavicle line, and on auscultation there is no buoy. Bowel sounds is present. On per-rectal examination, the anal tone is normal. The acolic stools were present on the fingertip of the index finger, and there is no palpable mass on the per-rectal examination. The external genital examination was unremarkable, and so was the respiratory and CV system examination.
Just a small point, some of the examiners are very finicky. So rather than saying percussion, no free fluid, say no evidence of free fluid. Because you cannot say that there is no free fluid. There could still be free fluid.
Yes. So to summarize further, in addition to my clinical history, on general examination, patient is well built, well hydrated with BMI of 23.1 kg per meter square and WHO performance status of 0. There is deep icterus present. And on abdominal examination, there is a healthy scar due to previous surgery. And on per-rectal examination, acolic stools are present.
Suppose you were the treating surgeon and this was the clinical course. Do you agree with the plan of management, whatever they have done so far?
Sir, they have done some abdominal imaging, and if I would be finding out the findings of those imaging, because patient didn't on post-operative post patient didn't had any fever or abdominal distension or any sign of sepsis, but on abdominal imaging maybe some finding was there, so that's why they.
No, What I am indirectly asking, would you have waited for 3 months in this case?
Sir, other than few specific situations, yes, I would have waited for 3 months, sir.
Like,
if after the ligation of clip on posterior two, if the duct is completely ligated, there is no bile leak, there is no sign of sepsis, there is no uncommitted vascular injury, and gallbladder is the jaundice is rapidly progressive. If there is on imaging, there is a suppose there is a CBD injury of type 1 or type 2. In those cases, I would have gone for surgery, early surgery.
so in this case, what do you think is the likely scenario?
So they were told in after the relatives were counseled that there was blood loss during the surgery. So maybe they had injured any vascular structure. And on abdominal imaging also they didn't find, they may have find any vascular disease, so they deferred the surgery that way.
Yeah. So what I'm saying, in all likelihood, this is what you also said, that this is a ligated duct.
Yes, sir.
There is no bile leak.
Yes, sir.
Patient never had sepsis.
Yes, sir.
Jaundice is progressive.
Yes, sir.
He's having significant pruritus.
Yes, sir.
What will be the reason to wait for 3 months?
Sir, any vascular injury?
So vascular injury, you would wait for how long? Suppose there is vascular injury, right hepatic artery injury. How long would you wait?
I wait for 6 weeks, sir. At least 6 weeks.
So, even if you want to wait, you will wait maximum for, and why do you want to wait in a vascular injury?
Because, sir, even if I make a repair, the stricture progression is going to be there because of the ischemia to the bile duct, because of the injury to right hepatic artery. So the structure will further progress.
But this is already ligated duct, isn't it?
Yes,
So
sir.
there is no question of stricture. This is what I was saying. There is a subtle difference between a ligated duct and a stricture.
Okay, sir.
This is a ligated duct. The duct is already completely obliterated, the lumen. There is no bile flow.
Ashish said, suppose I put it the other way now to you. Ashish,
Yes, sir. I'm listening.
other way round to you.
Yes.
You have done a cholecystectomy today,
Yes, sir.
and you find that the patient is in hospital. You had blood loss on table, and now on day 2, the patient is having a pruritus and jaundice. How will you proceed now? First thing, what you will do today? Day 2, you find the patient is having icterus and he says some pruritus is there. What is the first thing that you will do today?
I'll send blood investigation along with it. I will do a US abdomen.
Very good. What are the investigation that is the most important for you at this point in time?
Liver function test and
Yes.
CBC, sir, both.
And maybe with GGT, LFT with GGT.
Yes.
Fine. So in that, what will you look for?
Raised ALP, raised.
Yes, that is the most important thing. Raised ALP and maybe some OTP. Fine. Now you find that the patient is having alkaline phosphatase or something around 700. On day 2, you have done an open cholecystectomy. What is the next thing that you will do today now after your LFTS report has come?
USG abdomen.
USG abdomen. Very good. Now on USG abdomen, I say you find that it has mentioned there is some dilatation of duct. There is no free fluid present in the abdominal cavity. I think that is the scenario that you are having. Now, what next thing you will do now?
I'll do a
This
CC
will give you the
abdomen.
answer of what Dr. Kapoor is asking.
Sir. I'll do a CC abdomen also with the to delineate. No,
Why
no.
do you do? What do you want
No,
to do?
no, sir. I'll do an MRCP. I'll do an MRCP.
Good, good. So you will do a MRCP, but I would say that in this MRCP, you will ask your radiologist to find something other than this also. MRC, you are looking at the bile duct injury.
Yes, sir.
Fine. You're like looking at the bile duct ligation side. But now I say that you have to ask your radiologist to look at something else also. Will you ask your radiologist something else in this MR?
Retained CBD stone, sir. I'll ask him to look.
Since you have ligated, you feel okay. Retained CBD stone is the same thing that you can see. Fine, fair enough. I would say that I would ask him to look at a MR angiogram. So that will give you both the answers now. if you have a good anatomy with a good arterial and good venous, so you would like to do a surgery directly rather than.
Sir. In that case, I will. Sir.
Yeah. Second thing is, now I'm coming back to your LFT. Again, coming back to your LFT. Now, LFT, I told only increase alkaline phosphatase. There is a second scenario in which you have an increased alkaline phosphatase or something around 300 and SGOT and SGPT of 2000 and 1500 on day 2.
Yes, sir.
Now, how will you approach this patient?
So,
Are the two patients same?
no, sir. No, sir. This patient is having cholangitis. So I will further progress to manage the cholangitis.
No,
No.
enzymes in thousands means ischemic injury to the liver.
Oh, yes.
Yeah.
Yes.
Enzymes, Dr. Ajay specifically mentioned enzymes in thousands. So bleeding during surgery, enzymes in thousands, most likely arterial injury, isn't it? So we will come to the management once you discuss the investigation. But just one point at this stage I will mention, because you said that if there is a vascular injury, I will wait for 6 weeks or so. See, it is mentioned that vascular injury is a contraindication for either intraoperative or early repair. But it is not a contraindication for the delayed repair. Now, delayed repair, we say that once all sepsis has been controlled. Now, in this patient, there is no sepsis at all, either in the peritoneal cavity or in the biliary tree. So that hard and fast rule of 6 weeks may not apply in this situation. You may go for a relatively early, I wouldn't say early, but relatively early repair also. We'll see the investigations. The other thing, this point that the stricture will further progress up, yes, it is true. But the basic principle of a stricture repair is that irrespective of the site of injury or stricture, you do a hilar anastomosis, which means you always do the anastomosis at the biliary ductal confluence, extending into the left duct and into the right as much as it's possible. So already you are doing a highest possible, what I call a hilar anastomosis. Okay, so I think let's proceed with investigation so that we can discuss the management. Yes, please.
As Ashish told this regarding this complete ligation of duct, the time of repair will depend on the type of injury. Is the type of injury E1 to E3 with vascular injury, like right hepatic artery injury, we can go early repair because the hilar plexus is maintained. Or in case of E4 type of injury with arterial injury, then we have to wait for at least 1.5 or 3 months.
Yes.
Yeah. So what Dr. Anand was saying, that if the injury is below the ductal confluence, then the hilar communication between the right and left arteries is still there. But if the injury is involving the ductal confluence, then very likely that even that communication has been compromised. So the axial supply as well as the hilar supply, both have been compromised. Okay. So the anatomy of the stricture will be very important here. Dr. Chaube wants to say something.
You see, in a higher center like yours, efforts should be made to either obtain the old operation notes, or the contact should be made with the surgeon. And you will know, then you can ask all the questions pertaining to before you plan the final treatment. Because if the diagnosis by that surgeon was that he has tied the duct, because he's even if there was a blood loss, he will tell you that there was a blood loss and there was no bile leak, obviously, because immediately on ultrasound did not show any collection. And then you can see. So the surgeon, there's a very important thing in a higher center. Efforts should be made to contact the surgeon, or you should have the detailed operation notes.
So in the exam also and in your clinical practice also, whenever you are dealing with a bile duct injury, you must go back into the pre-operative history and investigations and the intraoperative findings as much as you can. Okay. Even if they are not there, you should say that I would like to know. Okay, please carry on. So this patient comes to you, what will you do?
Sir, I would like to review the records of the patient.
Let's see. Yeah, sure.
So we don't have the pre-operative imagings and the values.
That's
sir.
fine. Okay.
It was referred to us with the OT notes and the post-operative, the imagings of the post-operative course only. Imaging finding. This is the OT note we had.
Just a small suggestion I would give, since all of you are tomorrow going to become GI surgeons, whenever you get a patient with bile duct injury referred to you, make it a habit to call the operating surgeon, talk to him or her, try to get as much details as possible. It will serve two things. It will help you in management of the patient, and it will give the confidence to the referring surgeon that you are looking after his patient well, and then you are likely to get even more referrals.
Yes. So this is the operating note we had for the patient.
No, we are not able to see. I think you stop share and then share again. In the meantime, any question from the students? Anybody? Just unmute yourself or raise your hand. Otherwise, we will proceed. Yes.
So this was of the patient. The primary diagnosis of surgery was symptom called lithiasis, and he underwent cystectomy. The duration of surgery was 3 hours, and there was blood loss of around 500 ml, which was higher. The surgery was planned in elective setting, and in intraoperative course, the surgeon found out the gym was contracted and the colors was frozen, and the critical safety was could not achieve. He could not achieve that, so he went for a fundus push approach, and he clipped the cystic artery. And at that time,
we all have read it. Do you agree? Do you think that the operation notes are? Does everything tally with the other points mentioned?
yes, sir.
Let me ask you a direct question. The surgeon says Kellett's anatomy frozen. Critical view of safety not achieved.
Yes, sir.
In these two situations, the second statement, single cystic artery and duct, is not possible.
It's not possible.
If you are able to see cystic artery and cystic duct separately, then it doesn't tally with the statement that Kellett's is frozen. So probably there was some kind of
Identification.
I won't say mistake, but the perception of the surgeon probably is not correct.
It is further corroborated by the fact that having clipped the cystic artery, what he thought that is a single artery, so and then patient started having bleeding.
Yes.
So it means that either the cystic artery, what he thought was not the cystic artery, or there were some additional branches, or it was a hepatic artery.
Hepatic artery. Yes, sir.
Huh?
Yes, sir.
Anything else?
500 ml of blood loss also.
Safety for lap or for open also? No, you can explain it. You can. It is basically
actually
you have a view
in lab. In open, you don't have that much of view. Therefore, it may be not be a critical view of safety. Maybe it is maybe it will be a misnomer for an open policy.
But you can always, in the sense, for your own thing, if you follow that thing, so you are likely to.
So what Dr. Ajay is saying, that the term critical view of safety is actually described for laparoscopic cholecystectomy, because then you flip the gallbladder, see the anterior and posterior surface, both views. But I suppose retrospectively you can apply to open cholecystectomy also to show that the anatomy. But what we are trying to point out that the operative findings, all statements are not tallying with each other. Okay. Any other important point you would like to analyze in the operation notes about the control of bleeding?
Yes, sir.
Obviously, there is a large bleed there, and the surgeon has tried to control the bleed with a suture. So, can it indicate something?
Yes, sir. It can indicate there was a vascular injury to a major vessel.
No. The suture controlled via 3-O-proline suture.
Yes, sir. Yes, sir. So maybe there was yes.
So this suture itself, you see, when you are trying to suppose it was the right hepatic artery which the surgeon mistaken as a cystic artery, and then maybe clips were not properly applied or whatever, and there is a bleed from right hepatic artery. Now, if the right hepatic artery is running either anterior or posterior to the CBD, and you try to take sutures there, Kellett's triangle is frozen, you don't know where the CBD is, the sutures itself can go around or through the CBD and cause the injury. So injudicious attempt to control bleeding either by suture or by clip or by cautery can cause injury. This is what is a secondary injury, injury secondary to your attempts to control the bleeding. So during that process, the suture may have gone, if he has taken deep sutures, the suture may have gone around the CBD and now he has tied it. So it is not a ligated CBD because of the cystic duct being mistaken as CBD, but it is the attempt to control the bleeding which has resulted in a ligated CBD. That is what, and again, you see multiple calculi. So the point which we were discussing, that the initial presentation at least could be explained by CBD stone, although the future course, 3 months progressive jaundice, which is painless, is unlikely with CBD stones. Okay.
Suppose, Ashish, you were operating this patient.
Yes, sir.
And you were in the same scenario from point intraoperative findings, contracted is fine, Callet's anatomy is fine, critical view is fine. Now you find you have done a fundal first approach, there is a bleed. Now, what is your next step? If you were the operating.
I will put gauze pieces and mop to control the bleed.
Good.
And then after, if the bleeding minimizes, then I will like to see the the bleed and control it subsequently, sir.
So fair enough. So first thing is, that is most important, that you would like to control the bleed by a pressure packing and then pull. Now that is in an open cholecystectomy, that is the easiest way, pressure packing lagai. Even in lap chole, that is right way. Now, suppose after 2 minutes, 3 minutes, you have removed the gauze piece and you find.
Initially, when, in the 90s, Professor Kapoor's small presentation, I remember he used to have one slide of 5 P's.
Okay. Yeah. Secondly, now, do you think that the suture that you would have used would have been the same?
No, sir. No, sir. I would have used a 5-0 Pauline or 6-0 Pauline, sir.
Fair enough. So that is a very big hint. What Dr. Kapoor is actually exactly wanting to say, that it is actually the grossly showing you, it is telling you that 3-0 Prolin has been wrongly used at a wrong place, so the chances of injury is at that side. This is actually himself telling, the surgeon is telling you.
So the answer to Dr. Ajay's question, which you should say in the exam at least, and this is what you should do in practice, that I will apply pressure for adequate time, and then I will remove the pressure. Now, if it is say a venous bleed, it may have got controlled on its own. If it is a small arterial bleed, even the artery may have gone into spasm and controlled. But even if the bleed continues, now you will be able to better locate the site of the bleeding. And then, as you rightly said, you will try to control it with a fine suture rather than 2-0 or 3-0 Prolene. Okay? Yeah. Please carry on. There is a question from...
Can I interrupt, sir?
Yes, yes, please.
Yeah. Wouldn't you do a Pringles maneuver if you found bleeding at the callus?
Rajan, say again. I think we could not hear you.
Would you do a Pringles maneuver if you had a bleeding at the hilus?
That depends upon the amount of the bleeding, and pressure was more pressure. Applying a pressure was in most of the cases the bleeding, sir. But
I would disagree with you. I think the first step to stop bleeding, when there is torrential bleeding from the hilar area, the possibility here is, since he has done fundus first, he has either injured the right branch of the portal vein or the artery or both, and therefore the Pringles maneuver would immediately reduce the amount of blood supply. You use suction, find the source. If it's a venous bleed, then you have to repair the portal vein rather than ligate it.
Yeah. So one point which Dr. Rajendra Desai mentioned, that when you use a fundus first approach, especially in a difficult gallbladder, it can sometimes be dangerous, because as you go from the fundus to the body towards the neck, because the plane between gallbladder and the liver is not clear, by mistake you can enter into the liver parenchyma, and there the right main pedicle, or definitely the right anterior sectoral pedicle, lies only at a few millimeter depth, and it has been shown by Strasberg and Guma that fundus first approach is associated with major biliovascular injury, especially to the right main or right anterior sectoral pedicle. Now, there is a question from Vis that whether MRCP in this case at that stage, early stage, yes, as Dr. Ajay was discussing with Ashish, after doing an ultrasound, if ultrasound shows no biloma, CBD probably ligated with proximal dilatation, and you want to rule out a CBD stone at that stage, yes, definitely MR would be indicated in a case like this, which otherwise we will not do, because as Vis pointed out, when there is a biloma, there is no point in doing an MR, because you will not be able to visualize the biliary anatomy. If at all you want to do an MR in presence of a bile leak and bile collection, first you must drain the collection and then get the MR done. Okay, please proceed.
Second, I would like to know the histopathology of the patient.
Yes.
In this case, it was suggestive of chronic non-specific cholestasis with cholelithiasis.
Does this rule out, not in this case, but does a normal biopsy rule out a missed gallbladder cancer?
No, sir. No, sir. It doesn't rule out completely, because in routinely in the histopathology examination, they get the 3 slices of the gallbladder specimen. So in the glossing, so they may miss the missed gallbladder also in routine histopathology examination. Though it doesn't completely decrease the threshold of missed gallbladder.
Yes. Okay, next.
Then after in the abdominal imaging, first the CT was done, which
Was any ultrasound done at any stage at that time? No.
The patient was suggesting that first the ultrasound was done, then CT was done, but in the discharge summary didn't had the.
Okay. Okay. Yes.
So in the CCT abdominal examination, the right hepatic artery was not visualized from its origin, adjacent to the site of the cholestectomy clip line. And then also there was non-visualization of the common hepatic duct and the CBD for length of 3 cm with bilobar IHB. But
so what does this mean?
So it means the surgeon may have actually ligated both the right hepatic artery and the CBD at the same suture lines.
Yeah. Okay. So now what will you do? We have you. I can see you have an MR also at that time.
Yes, sir. Yes.
Show us.
So this was the report of the MR. We didn't have the film, and the gallbladder was not visualized. There was mild hepatic collection in the GV fossa and the perihepatic region. There was the collection was communicating with the CBD, resistive of a cystic substance, and the mid part of the CBD was not visualized for a length of around 3.3 centimeters. So, and distal CBD was normal, was measuring on. So there was maybe a segmental loss or of the CBD in the MR.
Okay. The biochemical parameters.
So these were not in the discharge summary. It was a single way discharge summary. So we have only these 3.
Okay, let us take you back to this December. So you saw this CT and MR. What would be your plan of management in this case?
Sir, patient had a concomitant vascular injury. So, but there was no sign of sepsis, and there was a ligation of CBD length. So, after this discussion, maybe I would have gone for a early repair in this patient.
Yeah, I suppose so. That if the anatomy is favorable, in spite of the fact that there is a right hepatic arterial injury and ligation, I suppose since the jaundice is progressively increasing, rather than risking an episode of cholangitis while waiting for the mandatory so-called 6-week period, I personally would probably go for an early repair as soon as the patient is ready, because this would be, since there is no significant bile leak and no features of sepsis, I suppose as an exception, I would go. Ajay, would you agree?
Yeah, I would agree that since it is only right at injury. Now, Ashish, if you have a similar scenario, but the CT showing that the main hepatic artery is ligated. There is no flow in the main hepatic artery. Now, will it change your plan rather than a right hepatic artery?
Yes, sir. Then I will not go for early repair. Sir. I will.
Why? How will it change your plan?
Sir, because if we are going to make a hyalojejunal anastomosis, the blood supply for the hyalojejunal anastomosis is going to come from the left hepatic artery, and now we have there is a loss of distal CBD, so mid CBD, so even the ascending blood supply is not going to be there from the GDA. So
you had an answer which was already given by Anand some time back. The important thing is that the hilum should have a supply. That is the most important thing. If you are having a right duct, a right arterial injury, the left artery will supply at the hilum. So it will supply even the right part through the hilar branches of the left hepatic artery, which will go at the hilum and give a good vascularity at the hilum to the bile duct, since you are doing a hepaticojejunostomy. Now, I would have said if I am having a hepatic arterial, main hepatic arterial injury, in this scenario, I would like to wait for some time so as to have a alternate blood arterial supply to the liver, which usually develops within few days. And now the patient will start having an arterial supply, but we don't know whether that will reach up to the hilum or not. So I have to wait to see if it is going up to the hilum, then the anastomosis will not ascend much higher up. In case the supply does not reach up to the hilum, then the stricture will ascend even more into the right and the left hepatic ducts. Getting the point? That is the reason when you have to wait for a longer duration to see how much the stricture had ascended up after the main vascular injury. So the term that vascular injury will not suffice all the things, whether it is a right ductal arterial injury, main arterial injury, or a portal venous injury. So all the three scenarios will be different.
So in a nutshell, the importance of vascular injury, especially arterial injury, which is more common than portal venous injury in bile duct injury or biliary stricture, is one, that even groups which would believe in early repair, they probably would not do early repair in these cases.
Yes.
Okay. Second, as Dr. Ajay said, you have to discern whether it is right hepatic artery injury, which is more common, rather than main hepatic artery injury, which is less common. But in complete misidentification, it can happen that you misidentify the CBD as the cystic duct and the proper hepatic artery as the cystic artery, and both are ligated and divided. So in that case, you will wait little longer, the point which you mentioned earlier. The third issue, which is very debatable, very controversial, that what is the effect of the arterial injury on the restricture of the biliary enteric anastomosis? There are reports which say that in presence of arterial injury, restricture is more common. There are reports say that it doesn't matter. So by and large, it doesn't change your management, except if you have a very high injury, the point which Dr. Anand was mentioning, where the injuries involving the biliary ductal confluence, right and left ducts are separated. So even if there is no proper hepatic artery injury, the collateral supply at the hilum also is disturbed, and there is an associated right hepatic artery injury. On the right side, the stricturing process is extending even into the anterior and posterior sectoral ducts. You don't get a duct for anastomosis, or you don't get a good duct for anastomosis. So the only implication it has is that it lowers your threshold for considering or doing a right hepatectomy as the first procedure, which is usually reserved as a second procedure, as a salvage procedure. But this is one situation where some people may say that I would like to straight away do a right hepatectomy, although there is no atrophy, but because you are not getting good ducts and the chances of restricture are high, a small advantage of right hepatectomy in biliary stricture is that your left duct exposure, left duct anastomosis becomes slightly better. But that is not the reason, that is an advantage. Otherwise, right hepatectomy in the first go would be indicated more frequently when there is a portal venous injury causing atrophy, hypertrophy, or there is recurrent cholangitis and cholangolytic abscesses mainly confined to the right lobe. Okay, anything else you have?
Then I have the investigations in the Feb only. So these are the investigations I have during the presentation to our OPD.
Yeah, that's okay. No, anything else which changes our discussion or plan of management? Any other information? You have a Doppler report?
Doppler was actually, I don't have the Doppler report. I have Doppler done with us.
Yes.
Yes. So this, there was absence of right hepatic artery flow, and
so same findings. Okay, fine. Any question you want to ask us? Any doubts? Any queries?
I said this was one query I wanted to have, that would I go for an early repair in this?
So again, I would say that by and large, most groups, including us at SGPGI, were not in favor of early repair, especially in patients who had a bile leak, biloma, peritoneal, or biliary sepsis. The best time to manage such an injury would be once all sepsis has been controlled, patient has recovered from all sepsis. If there is an external biliary fistula, it is showing trend towards closure, then you wait for it to close so that there is a stricture formation with proximal dilatation. That is the ideal time. But there are exceptions. One exception is, as you also were trying to say, a ligated duct, no bile leak, no peritoneal sepsis, no biliary sepsis in the form of episodes of cholangitis, favorable anatomy, the point which Dr. Anand mentioned, which means type 1, type 2, or a good type 3. Good type 3 is what Dr. Sadiq Sikora described, where the confluence is formed and it is not involved in the fibrotic process. There are cases where technically there is a confluence. So if you do a PTC or you do an intraop cholangiogram, the dye goes from right to left, but it is a very narrow, scarred communication. So that is a bad type 3, which behaves like type 4. So if the biliary ductal confluence is involved in the fibrotic process, there is a high possibility that this hilar collateral channel is also interrupted. So in those cases, you would like to wait. Second exception is that if it is a complete transaction with external biliary fistula, and you have waited for 2 months, 3 months, 4 months, this is a frequent question which we examiners ask, how long will you wait? So the answer is that if it is a complete transaction, the chances that the fistula will close are about 50 to 60%. Now, nobody can predict which of this fistula will close, but you see the trend of the output. If the trend is towards decreasing output and closure, then you wait. If the trend is that it is not decreasing, the output is remaining same over a period of, say, couple of weeks, then you say that this fistula is unlikely to close. You don't want to wait any longer, and you will go in with the ongoing fistula. Now, if you go in with an ongoing fistula, the disadvantage is that the ducts are not dilated. The advantage is that the fistula's tract leads you to the duct. So identification of duct is usually not difficult. How long do you wait? Nobody knows, but most examiners would accept 3 to 6 months. Nobody would wait for more than 6 months, because then you run the risk of secondary biliary cirrhosis, either because of recurrent cholangitis or even without cholangitis, just kind of biliary stasis or biliary obstruction. Some people would be even more conservative. They would say, no, I wouldn't wait beyond 3 months. So I think best for you to say would be around 3 to 6 months. And as I again and again say, there is no single correct answer. You should be able to discuss the question and discuss your answer.
Yes.
Any student, Krishna, you want to ask anything? Any student online wants to ask anything? Any faculty member online wants to make any comment? Rajendra, anything else you want to add?
No, sir, that's about it. For this level, this is more than enough.
Dr. Banerjee, you want to make any comment? Okay, then. Shall we close?
Yes, sir.
Okay, thank you. Thank you, Ashish. Thank you very much. So next week, I think Jaya is scheduled to make a presentation, but she wants to present a case, na, Jaya? So Jaya has said that instead of operative surgery as intimated by Dr. Anand, she wants to present a case. So that is fine with us. I have requested Dr. Sujoy Paul, who is a professor of GI surgery at AIIMS, to join me for discussing the case. Okay, thank you.